The next step of EP procedure, AF ablation procedure, is transseptal puncture. I think the most stressful and the nervous procedure for the beginner might be the transseptal puncture, because it has a risk of cardiac tamponade and serious complications. But if you keep the rule, it might be very, very safe procedures and easy procedure. You can use any kind of transseptal sheath, but I prefer to use Schwartz left 1 sheath, SL1 sheath usually. And there's 2 parts. Tip of the sheath is generated by the rubber. When you enter this sheath inside the skin, if there is some resistance, don't hesitate, pull out, and use mosquito and dissect the soft tissue. Then you can easily push inside the vein. Okay? And when you put your sheath tip left innominate vein, then you need to remove guide wire and exchange it with the broken bone needle. Okay, broken bone needle shaping is actually the key process of transseptal puncture. You need to shape this broken bone needle depending on your anatomy. When you put the CS catheter and the standard catheter position, I think you can guess where's the septum and how's the angle of septum. So when you make a curve of this broken bone needle, it depends on the right atrium size. If right atrium is very huge, you can make a big curve like this. If it is small, very small right atrium, you can make a small curve like this. And if septum is straight up, you should make a right angle. If septum is very slanted, like old people, you can straight up the needle. Okay, so make sure the curvature of broken bone needle is dependent on the right atrial size and the septal angle. The SL1 sheath still in the right side innominate vein, and then you need to push your broken bone needle inside. When you push the broken bone needle inside the SL1 sheath, please keep the stylet. Don't remove this stylet. Okay, this stylet put inside of the broken bone needle, because the needle tip is very sharp, and after shaping, sometimes the tip of broken bone needle scrape out the plastic part of dilator. So it is safe to put the stylet inside, then push you need to remain the 2 finger breaths between the dilator tip and the needle. And also it is important to keep the angle of side arm, and there is the French marker, round ring marker, and the needle should be parallel altogether. This one should be parallel. Innominate vein to down in LAO 35 degree, and there's 2 jump, because there's aorta contact area. There's 1 jump, and there's fossa ovalis and 2nd jump. If you can see your dilate tip located in the fossa ovale, then you move to fluoroscopy to RAO 35 degree. Okay, RAO 35 degree, your sheath probably direct like this. And you can move down, upper, anterior, posterior. If you want to move the dilate tip anteriorly, counterclockwise torque make anterior direct, and the clockwise torque make posterior direct, right? But make sure the proper location of your dilator is between his-bundle catheter. His-bundle catheter location match to their aortic cusp, and their posterior cardiac silhouette, posterior 1/3. Between his bundle and posterior cardiac border and posterior 1/3 position might be the proper position for transseptal puncture. So in RAO 45 degree, you can adjust your catheter position, and then come back to LAO view and watching the location of tip of dilator, and gently whole system, and probably tip of the dilator make a tent of the septum, and gently push the needle inside and push inside the dilator, then sheath in, and you can remove everything. After takeout, after the generated successful transeptal puncture, please remove 5 cc of blood outside and then flush it, because your guide wire put inside the body quite several minutes, and potentially there's some aggregated clots. So please remove 5 cc of blood, take away, and then flush this sheath and start your procedure. This guide wire is put inside of SBC, and we put the transeptal sheath put into the innominate vein along this guide wire, and make a small incision on the skin. And because the tip of transeptal sheath made by rubber, if you push it more vigorously, you can damage the tip of this sheath tip. Then it is hard to pass the transeptum. So if you feel some resistance on the skin, you can dilate it by mosquito catheter. And now transeptal sheath is already inside of innominate vein, and remove the guide wire. The location of innominate vein is just 1 vertebral body length higher than trachea bifurcation, and you remove the guide wire, and then flushing, and put the transeptal needle, broken brow needle, inside of dilator. And it is very difficult. It is very important to shaping the broken brow needle depending on the right atrial size and the septal angle. So we put the long needle inside of dilator, and the 2-finger breaths should be separate from the tip of dilator and the broken brow needle marker, and the side arm marker and broken brow needle marker should be parallel altogether. And in the LAO view, LAO 35-degree view, we pull back the catheter, and in this position you should make sure you can see the radial opaque marker at the tip of the sheath in between the dilator. It should you should maintain this marker linear position. If you see the ring shape, your broken brow needle is tilted anteriorly, posteriorly. So you need to keep this marker in the linear position, which means you are maintaining the maximum curvature of a broken brow needle. Okay, and here you need to rotate your fluoroscopy to RA of 45 degree, and you can estimate where is the posterior cardiac border and the hip bundle location. So the proper position is posterior 1/3 in between hip bundle and the posterior cardiac silhouette. Then, if you believe your needle position is correct, move back to LAO 35 degree and the puncture. So in this patient, probably the interatrial septum is very thick. It's very hard to push the dilator inside the LA. So if you think that you puncture the transeptum, interatrial septum, but there is no draw of blood to the syringe, do not push your dilator at all. It is very, very important. If there is no blood in the syringe, when you draw back the syringe, your needle tip is not the proper position. So never try to push your dilator inside. Yeah, still there is no blood. Yeah, I push it hardly, but still there is no blood withdrawal. So in this time, you can choose plan B. Number one is you can try to use stylet already inside of a needle. Yeah, when I put the stylet, you saw the tip of needle popped inside of LA successfully, and you see the blood withdraw. Then you can safely push your dilated inside and successfully pass to the anterior septum. And second choice, you can use the RF needle. And third one, you can use a low energy Bobby power on the tip of the broken bone needle.